Let's talk a little bit about artificial disc replacements. There is some confusion out there about what this technology is. Sometimes patients are confused about what artificial disc replacement technology is. Is it experimental? Is it available for everybody? And what is it used for? And I'll toss that over to you, Dr.
Yeah,
Patel.
I'll start by saying it. The good news is that it's not experimental, right? It is well established. There's actually lots of clinical trials demonstrating how effective disc replacements can be. I think it is also, though, that, again, to go deeper, it's not a universal fix either, right? There's a lot more information that we need, and I'm sure my colleagues here will talk about that, to try to figure out who's the right candidate, who's the right patient for a disc replacement, and then what's the right disc replacement for that patient. So I think there's a lot more information we need, but to answer your first question, not experimental, it is available, it is FDA approved,
Right.
And it's an exciting avenue of work that we're all heading into.
And a lot of patients are getting this treatment and doing extremely well with it. So given the information that is available and the FDA approval of these technologies, it is an option for certain patients. Dr. Gogawala, is this a technology that you use in your practice?
Yes, and I would say that, you said motion is lotion. I think most of us, as we move along in our practice, we don't know the exact type of patient in every scenario that's ideal for either the artificial disc or another motion preservation type of surgery. But I would say that in my practice, I am looking more and more to see how do I preserve motion when I treat a patient with a spinal cord or a nerve problem in their neck. Because the fusion, which is where you fix part of the spine together, the fusion operation is also very, very successful. But patients, by and large, if they are candidates for motion preservation, they do better in the long term. And so I'm trying to, in my practice, look to broaden the applications for these motion preservation techniques, whether it's arthroplasty, the artificial disc, or another operation that preserves motion called laminoplasty, which you do for the back of the neck.
Dr. Albert, do you see cervical disc replacement in your practice?
Yes. What I see is so many people on the other side of it, the patients come and they hear about it and they come and say, I want a cervical disc replacement. And the harder conversation is not like you're a perfect candidate, because we have many good candidates. We have still, as Zoe said, we still are defining who the right candidate. And when something gets released and there's an enthusiasm, and what I see are a lot of people that probably shouldn't have a disc replacement, if they have too much arthritis or spondylosis in their neck, or other reasons, or instability, that's not a correct patient for disc replacement. Yet they heard about it, I said, I want a disc replacement. And then you're in this conversation where you're saying, no, it really is. If you were my family member, I wouldn't recommend you have a disc replacement. So we have to help define and counsel patients that there are perfect patients for disc replacement, those patients with a beautiful, youthful looking neck, not much arthritis, herniated disc at one or two levels, perfect patient for disc replacement. Not the very arthritic patient, or what we call kyphotic, where their neck is bent the wrong way, or they have instability, or they have an injury or fracture. Not the right patient. And so it'd be a bad operation. The device is great. We as surgeons and physicians have the responsibility to help define the perfect patients for it, the good patients for it, and what kind. There's now different types of disc replacements. How much constraint? How much does it move? How flexible is it? There'll be ultimately different disc replacements for different indications.
Dr. Meraz, your experience with artificial disc replacement in the neck.
Yeah, it's one thing that I think the community of spine surgeons have done right. We put a lot of effort in the appropriately designed studies to bring this technology to market. And right now, when we talk about cervical radiculopathy, we have three primary options, one of which is, as Alpesh mentioned, a posterior phalangotomy. Another one, as Zoe appropriately mentioned, is an anterior fusion. And finally, we have the disc replacement. And just like the panel has said, we have to appropriately match the patient to the right surgical technique and procedure. Ultimately, one of the goals obviously is to make patients better, but the ultimate is really a principal goal that we have is to make sure it's a durable outcome. And what we don't want to do, and I think Zoe alluded to this, is to do a procedure that can potentially lead to a problem. In the case of fusion, why this seems to be really an attractive option for us in this motion preservation is because when we do fuse a single segment of the spine, the level above or below can in fact break down. And we know that this happens in a certain percentage of patients at various time points following the surgery. And so I think the disc replacement technology or the motion sparing technology it's an attractive option right now. And I think over time, we're going to learn more and more and more and finally dial in the right implant for the right percent.
I'm gonna build on that and say that is a big driver, right? Patients will come, they're worried, and they hear stories that if I have one spine procedure, I'm gonna automatically have another and another and another. I think we hear that in lower back conditions and in neck conditions, and that fear is a big driver for why people are looking for solutions. And disc replacements in the neck, motion preservation, if we focus on the anterior-based components, they came to market hoping to solve that problem. And there are some studies that suggest that for some patients, you can reduce the risk of that next level going out. I would maybe argue and say that that's not proven across all patients. We have a really hard time predicting who's going to have another disc problem and who's not. And to some degree, it's a bit of biology at play as well, right? Like we can't stop the aging process. So the conversation I oftentimes have with my patients when we're thinking about fusion versus disc replacement is a pro and con, right? We may have a potential benefit for you, but we may also see problems 10, 20 plus years down the road with the disc replacement. And oh, by the way, none of that stops the aging process. So the thing I tell them is that we can't make many guarantees in spine surgery, but I can guarantee that in 5 or 10 years, they're going to be 5 and 10 years older, right? And so will their discs. So I think we'd love to present it as this phenomenal solution for all patients, but again, the reality is that that's not where we're at.
Yeah. And I would just say another motion preservation procedure is a total knee or total hip replacement. But we need to start thinking, and patients should start thinking about it. When they have a disc replacement, it's almost like they had a right hip replacement. Well, the patient has a right hip replacement. When 3 years later, they come back with a left hip pain and need a left hip replacement, they don't blame the right hip replacement for the left hip replacement. But as spine surgeons, when they have a C5-6 disc replacement, which is not unlike a hip replacement, when they need a C4-5 disc replacement a few years later, somehow the 5-6 gets blamed for the 4-5, but it's not. It's an analogous situation. Just they're more their biology and their genetics. And I always say to them, the reason you need that next surgery is the same reason you came for the first surgery. It's not the first surgery. It's the reason you came for the first surgery. That is most probably the reason for the second surgery.